Noon to our last day of SABCS. This is one of the plenary talks that Dr. Carey has put together. So Dr. Lisa Carey is Deputy Director for Clinical Science at the University of North Carolina in Chapel Hill and the Lineberger Comprehensive Cancer Center. Her talk today is going to be triple-negative breast cancer, pitfalls, and progress.
Thank you so much. It is really a pleasure to be invited to give this talk. If we could pull up my slides. Thank you so much. So my disclosures. So here are the characteristics of triple-negative breast cancer. These are highly proliferative. They typically have high Ki67. They're hormone receptor negative, HER2 negative. This is the ASCO CAP guidelines. They are largely ductal, but there are some other histologies that have some slightly different behavior. And of course, if we concentrate on the ER, PR, and HER2, that's why, in truth, we have only for relapse risk reduction chemotherapy-based approaches. So there's a lot of heterogeneity within triple-negative breast cancer, histologic, biologic, and microenvironmental. You know, Virginia, this is not my talk. This is an old talk. Yeah. Do you think they can find the one that I uploaded? We're going to take a brief hiatus because this is about a 3-week-old talk, and we're going to get the current talk up. This is what happens when you actually upload things more than once. Trying to be good. It says final. Why don't I just go ahead? Although this thing. Okay. I can go get my computer and make sure.
Yeah.
We'll go 5 minutes late.
Sure.
Okay.
We'll take a quick break. We'll find the right talk.
Okay. All right. Now we're really going to start this. So, triple-negative breast cancer, pitfalls and progress. So I'm going to frame this in the usual fashion with triple-negative breast cancer, doing the bench to the bedside, but then at the end I'm also going to incorporate some of the relevance of this for our communities. We'll talk about what is triple-negative breast cancer, how do we treat it, how can we get better, and what are the implications for population health. So let's start with the name. So triple-negative breast cancer, of course, is pragmatically named. It's named by the fact that it doesn't have any treatment targets at the moment, and we all look forward to being able to retire the name. Characteristics, we talked about a second ago. It is highly proliferative. It is, of course, characterized and defined by being ER negative, PR negative, and HER2 negative. And of course, there are some special histologies that sometimes warrant special attention, but they are typically quite rare. So let's first talk about the bench. So heterogeneity within triple-negative breast cancer falls in multiple categories. There's histologic, there's biologic, and there's microenvironmental differences. And I'm going to talk about each of these separately. So I don't think any of us can get away with the talk about biology of breast cancer without starting with the molecular taxonomy that my dear friend and colleague Chuck Peru created now 20 years ago with his seminal paper in Nature, the luminal A, luminal B, Claudin-low, basal-like, and HER2-enriched subtypes. And then Dr. Pratt has taken that one step further and took a large number of triple-negative breast cancers and did intrinsic subtyping, and has, as others have also found, that triple-negative is largely basal-like within those intrinsic subtypes. Basal-like is largely triple-negative, and there are some characteristic DNA aberrations that are found. P53 mutations are in virtually all of them. RB loss is common, PIK3CA amplifications, MYC amplifications, and BRCA1 and 2 functional loss. And I'm just going to point out, for those of you who have heard Dr. Andre's presentation, it is worth noting that very few of these actually fit into what he would call ISCAT1 or 2 abnormalities, meaning therapeutically targetable. The taxonomy has evolved since then. So if the hierarchical clustering I was just talking about is on the far left, we've also moved into eras of more sophisticated transcriptomics on specifically within triple-negative breast cancer, and that's where the Lehman and the Burstein subtyping have come from, which typically find basal-like subtypes, they find immune-activated subtypes, and they find typically a luminal androgen receptor subtype pretty consistently. I'm just highlighting a couple of new things for those of you who heard Dr. Andre's Outstanding Investigator Award talk. As we move into potentially even more drug target discovery approaches, proteomics and proteogenomics may be key to getting better in the future. Now, of course, intrinsic subtype informs decision-making clearly in hormone receptor positive, HER2 negative, and now increasingly appears relevant in HER2 positive. But it hasn't really been that helpful in triple-negative breast cancer. And I'm showing you here an example of an early data set, early triple-negative breast cancer from CLGB 40603, a neoadjuvant clinical trial of chemotherapy, demonstrating that subtype using the intrinsic subtype, the Lehman subtype, or the Burstein model, there isn't really a lot of particularly relevant information that helps us treat patients better. Similarly, in the metastatic setting from the TNT trial, outside of germline patients appearing to do better with single-agent platinum than single-agent taxane, it was really dominated by the basal-like, so it's hard to make much of therapeutic relevance there. So what I would call these is scientifically interesting, but of limited clinical value at the moment. But what about the microenvironment? So the microenvironment and immune infiltration, a couple of basic points. The first is that, as we all know, breast cancer itself is less immune activated than many other tumor types. There are fewer non-synonymous mutations, and that's shown in that seminal Nature paper. You can see breast is outlined in the red arrow, and unfortunately, it's on the left side of the diagram. But among breast cancers, immune activation is highest in triple-negative breast cancer, and that's whether you're using immune gene expression or TILs. And TILs themselves, I mean, again, heterogeneity being the name of the game, TILs percentage-wise vary widely within triple-negative. There are some that are quite quiet. But when they're present, they are prognostic in chemotherapy-treated triple-negative breast cancer, as shown in the upper right-hand side. That's triple-negative in Big 298. and also in treatment-naive triple-negative breast cancer. In the lower right-hand corner is an untreated data set of small node negative triple-negative breast cancers, which of course raises the question of whether we might someday identify a group at such low relapse risk that we can omit chemotherapy. TILs are also predictive of chemotherapy benefit. This is nice work from Dr. Karsten Denkert. I've highlighted the triple-negative box, but demonstrating the chemotherapy benefit in PCR if TILs are present. But as you can see, the same is true of all the other subtypes too. But defining immune activation is itself a work in progress. There's a lot of effort in trying to figure out how to do it. We have TILs, which are easiest. They're now reproducible and standardized. There's PDL1 immunostains, which have clinical utility for immune checkpoint inhibitor effect, at least in the metastatic setting. We have immune gene expression signatures or RNA expression of individual genes, and we have immune cell clonality assays that are coming to the front. But I think among the things that I found the most interesting recently are the idea that it's not just about how many immune cells you have in the tumor and not even whether they're activated or not, but it's also where they are. So on the upper right-hand side is something I think we're all becoming a little familiar with, the vernacular of fully inflamed, stromal restricted, margin restricted, and immune desert, which really relate to where exactly the immune cells are in the tumor, not just if. And then on the bottom, some really intriguing data that this kind of spatial localization of the immune cells are both, they were prognostic in that original Grosso paper, but they're also predictive. And you can see to chemotherapy on the lower left, and also to ICI benefit in the NeoTrip data that was presented earlier this week by Dr. Bianchini. Well, what about the clinical aspects? So I had the pleasure of working with some brilliant epidemiologists and molecular epidemiologists at UNC who have run for years the Carolina breast cancer study. SABCS is a prospective population-based series of studies in North Carolina. They are designed to oversample Black patients and premenopausal women with newly diagnosed breast cancer. And I'd like to just say phase 3, which you'll hear a little bit about, was actually named after a dear, wonderful patient of mine, Jeannie Lucas, who was a triple-negative patient who ultimately died of her disease. The clinical features are shown here. This was from the original CBCS phase 1 and demonstrates something we now know to be true. These patients with triple-negative breast cancer tend to be younger, they tend to have higher stage of diagnosis, and their tumors are mostly high grade. These tumors are also overrepresented amongst Black women. I'm just honing down on that particular element on this slide, which demonstrates, if you look in the red, the triple-negative group, and I'm just going to caution you, CBCS, because it oversampled Black women and young women, the numbers aren't really population-based, they represent the CBCS. But the proportions and the relationships are actually quite valid, and what you see is essentially a young African-American woman is about 3 times as likely to have a triple-negative breast cancer as an older Caucasian woman. There's also characteristic relapse features. So first off, relapse is more common than other subtypes, and it happens earlier. And that what's shown on the right is from Rebecca Dent's really nice illustration showing a higher peak, which is the rate of relapse, but also that it falls off around year 5 or so. And in fact, there's a nice paper that looked at a large group of triple-negative patients who had reached the 5th year without relapse and calculated their risk of relapse in the subsequent 10 years, and it's less than 3%. Their sites of involvement are characteristically lung and lymph node. Distant lymph nodes are the most common sites. And it's worth noting, as many have noted, CNS relapse is a problem for this group. Tends to be about 10% in an early site and gets up to about 40% over time. But we have had some good news in triple-negative over the last few years. I mean, this is a data set from the British Columbia Registry just demonstrating the triple-negative breast cancer, which again on the left it shows the early risk of relapse and falling off. But if you go to the right-hand side, that's a couple of decades later, and you see that while it still has that early peak, it's been blunted. And that's the effect of better chemotherapy regimens and better treatment of our patients. This is actually not reflecting the stuff that we're doing now. It predates capecitabine, it predates immune checkpoint inhibitors, it predates adjuvant PARP inhibitors. Another significant advance that particularly matters in triple-negative breast cancer is the ability and the move to administering our drugs in early disease in the neoadjuvant setting. This is now true of virtually everyone except for the smallest node-negative tumors. So getting back to that CALGB study I mentioned earlier, that is, of course, a neoadjuvant chemotherapy trial exclusively in triple-negative breast cancer, testing chemotherapy permutations in that setting of bevacizumab. But there was a prospective surgical sub-study built into the trial, run by Mara Golshin and David Olilla, that found a couple of really interesting things. It was prospective, meaning the surgeons had to identify the extent to which the tumor was resectable or not up front. And they found that patients that were initially ineligible for breast conservation after neoadjuvant chemotherapy in a triple-negative group, nearly half converted to being a lumpectomy candidate. And if it was tried, 80% were successful. I think even more relevant clinically is the idea of node-positive cancers and trying to avoid axillary node dissection. Anna Weiss has done a recent analysis looking at the node positives and the conversion to node negative in those we knew were node positive up front, and it's nearly 70%. But of course, I'm a medical oncologist, so I talk mostly about the medical oncology relevant things, which is, of course, the pharmacodynamic effect of PCR and residual disease and the drugs we give in the early setting and the relevance for that in outcome. You can see here again from 40603 a really nice delineation of the importance of PCR and each of the extent of residual disease burden on outcome. This is not limited to 40603. As we all know, there's a number of trials that generally show the same thing, which is there's an incredibly strong relationship of PCR to outcome, particularly in triple-negative breast cancer. It also demonstrates that we have much higher PCR rates with modern polychemotherapy, and that if you look, you can see the EFS for PCR is really quite high for a triple-negative. Again, these are typically stage 2 and 3 patients that participated in these trials. Conversely, the residual disease groups still have a pretty, an unacceptably high relapse rate, even in the Keynote 522 at the bottom, the ones that got immune checkpoint inhibitor. So this is, of course, our opportunities, right? So this is where chemotherapy escalation in residual disease comes from. The original one of these was in triple-negative, was the CREATE-X trial design. That was in residual disease in HER2-negative. It wasn't a triple-negative trial. It was a positive trial, but the results were really driven by the triple-negative subset. And this was a trial where they got either 6 months of capecitabine or not in the setting of residual disease. And you can see the impact in the triple-negative group is on the bottom for disease-free and overall survival. And just point out an overall survival advantage of 8.5% is bound to catch people's attention, which it did. And this, of course, changed practice right away. So the other thing we have, of course, now are PARP inhibitors. And PARP inhibition in early breast cancer, which is the focus for this part, is, of course, demonstrated in the Olympia, which was presented earlier this year and published in the New England Journal. And this was adjuvant olaparib in germline BRCA-associated breast cancer with an 8.8% difference in 3-year invasive disease-free survival in favor of a year of olaparib after chemotherapy. Now, this is in this session because more than 80% of them were triple-negative breast cancer. And I think it's also true that while this trial was limited to germline BRCA1 and 2 associated tumors, we have reason to believe you can generalize this to germline PALB2, somatic BRCA1 and 2 mutations, and so that may expand the pool of those appropriate for this intervention. It's also worth noting that neoadjuvant PARP inhibitor given to germline triple-negative breast cancers, which is shown on the right-hand side, gets close to chemotherapy PCR rates. So that may also provide opportunities for us to try and limit or omit chemotherapy. But of course, the biggest change that's happened, and the most recent one, is the advent of immunotherapy added to neoadjuvant chemotherapy. And I'm showing you here, there have been a number of really beautifully designed trials that illustrate this that are shown here. But consistent themes in them is, first, in general, when you add an immune checkpoint inhibitor to chemotherapy, you increase the pathologic complete response to a greater or lesser degree. Second is the immune checkpoint inhibitor benefit is in the early setting not related to PD-L1 status, although most are PD-L1 positive, and this differentiates it from metastatic disease. And it's also worth noting, as I mentioned a little earlier, the truth is that Immune-activated tumors respond to everything we give them more than immune-not-activated tumors. Immune checkpoint inhibitor, chemotherapy, what have you. And then finally, the optimal chemotherapy backbone going along with the ICI is at this point not yet known. But let's focus on Keynote 522, which of course was the practice-changing trial. In this trial, patients received 4 chemotherapy drugs with or without pembrolizumab, and then post-operatively they received the continuation of pembrolizumab in that arm. It had dual primary endpoints of PCR and EFS. Here are the key considerations and the findings of the trial. You can see on the right-hand side the impact on event-free survival that drove this into the clinical practice. But it's worth noting, more than 80% of these tumors were in fact PD-L1 positive, which is about twice what you would expect in the metastatic setting. And as I mentioned, it was not predictive of benefit of the ICI. Eligibility here was essentially any triple-negative breast cancer that wasn't a really small node-negative one. And what we saw earlier this week from Dr. Schmidt was an update across clinical subsets, which says essentially that's still the eligibility for receipt of ICI. There's a pathologic complete response augmentation with the addition of about 7 to 8%, and a similar improvement in event-free survival. It's also worth noting there is no free lunch, right? So there's grade 3 or greater immune toxicity. It's markedly augmented, not surprisingly, by the incorporation of ICI, and we should recognize this is curative intent therapy, and these can be lifelong toxicities. So this changed practice for the majority of early triple-negative breast cancers with a great effect, but we also have to recognize new management strategies are needed. I'm spending a lot more time with my endocrinology and rheumatology friends than I ever did before. Now, what about metastatic disease? So I'm showing you here metastatic triple-negative breast cancer, the subset in a large metastatic registry we have at UNC, comparing 10 years versus 10 years and not seeing a lot of improvement in metastatic outcome during that time frame. And this has been shown in a couple of other papers. And unlike other subtypes, there's little evidence of improved survival after distant metastasis in triple-negative, at least up to a couple of years ago. I'm actually going to show you why I think these curves are about to change. So we'll talk about smart chemo. We'll talk about new tumor-targeted agents. There's a question mark there for a reason. And then the microenvironment. So the first is, of course, the advent of antibody-drug conjugates, which have changed the way, certainly we treat triple-negative, also in HER2-positive, and are clearly the wave of the future for how we give chemo. So what's shown on the upper left is a diagram of sacituzumab govitecan, which is anti-TROP2 antibody linked to an SN38 or topo-1 inhibitor payload. And you can see on the right the seminal phase 3 trial ASCENT, in which patients with metastatic triple-negative breast cancer, on average 3 lines of therapy into it, who received either treatment, meaning chemotherapy of physician's choice, versus sacituzumab govitecan, showing a clear and easily demonstrable improvement even in overall survival. So I'm not calling this targeted therapy, I'm calling this a really smart way to give chemotherapy, but that's okay, I like giving chemotherapy well. And there's lots of ADCs in development. So some have already failed, some are succeeding. We had a beautiful presentation by Dr. Kropp earlier this week on Dato-DXd, also an anti-TROP2 ADC in pretreated metastatic triple-negative breast cancer. You can see the waterfall plot showing clear evidence of activity in a small trial. So this is also hugely promising. But what about some specific tumor targets? I mentioned the PI3 kinase pathway earlier in the talk. There were 2 promising phase 2 trials, PACT and LOTUS, that look like we may be incorporating inhibitors of this pathway into routine care. However, there was a negative phase 3 opportunity triple-negative cohort, even selected for those with pathway alterations, and that's shown on the bottom. And the other large phase 3 trial, Capitello 290, is not yet reported. Now, there are some ways we might be able to get better at leveraging this particular pathway. There's preclinical synergy with immune checkpoint inhibitors that may improve targetability, but I would at the moment call this a work in progress. And then if we look back, there's actually some lessons learned about targeting signaling pathways in basal-like breast cancer. So you may remember from the original Peru intrinsic subtypes basal-like, the biggest, fattest target in basal-like breast cancer was EGFR, which is almost universally activated and is a hallmark of basal-like breast cancer. Unfortunately, EGFR inhibitor trials were disappointing, and surprisingly, to be honest, at the time. And I think we got some hint from our collaboration with laboratory-based scientists who could tell us why things didn't work when they didn't, and sometimes why things work when they do. Katie Hoadley, in this case, did a lovely job looking at serial biopsies and showed us that while EGFR activation appeared to be present in most of these tumors, the signaling was ineffective in some of the tumors, and there were alternative pathways that the tumor used in other cases. Similarly, RAS-RAF-MEK pathway activation is also common, and Gary Johnson and John Zawitowski at my institution did a MEK inhibitor window trial looking for combinatorial strategies because they assumed there would be reprogramming and the need for combinations. What they, however, found is a strong adaptive bypass response that involved, unfortunately, multiple tyrosine kinases. So triple negatives reprogram in response to many targeted agents, and that fungibility is a bit of a problem for specific agents. The next thing I'd like to talk about is targeting BRCA-ness. So we mentioned in the early setting the importance of PARP inhibitors. Of course, we all are used PARP inhibitors in the metastatic setting in germline carriers also. And it's true that either germline or somatic BRCA1 or 2 mutations are in up to 20% of triple-negative breast cancers based on TCGA. And of course, the hallmark there is ineffective homologous recombination DNA damage response. We use these based on beautiful data from BRCA and Olympia that are shown there. There is a supposition, and this has been a couple of decades now, of identification of similarities in certain sporadic breast cancers, specifically triple-negative ones, to germline BRCA-associated tumors that has been called BRCA-ness, and there's been a number of efforts to try and identify BRCA-ness in order to identify wild-type tumors that might benefit from PARP inhibitors. I can say that single-agent trials in wild-type triple-negative breast cancers have been disappointing thus far. But there are some ways of trying to augment that, and one of them is synergy between PARP inhibition and immune checkpoint inhibition, and it seems to be regardless of the status of BRCA and PD-L1. There was a study called Tapasio that we've all aware of because it showed a nice response rate of 21%, although I would highlight that in the germline carriers that were part of that study, it was almost 50%. So it's encouraging, but it's still a little unclear whether this is just the germline patients driving all of the results. There's also a nice study of maintenance PARP inhibitor with or without anti-PD-L1 called DORA, and we're anxiously awaiting some of those results. Again, a small study, but it would be proof of principle. So what would I say about PARP inhibition in wild-type BRCA patients? Triple negative, not yet. We know it works in germline BRCA1, 2, and there's evidence in PALB2 and somatic BRCA1 and 2 mutations from TBCRC 048. Pretreated triple negative with BRCA-ness features not otherwise specified, I would say no. But there are some efforts to try and identify triple negative with BRCA genomic scars using CORD or HR Detect, and I think those are still in evaluation, and combinations also. So again, beyond germline is still something we're working on. And then what about targeting AR? I mentioned that every subtyping method always comes up with a small proportion of triple-negative breast cancers that are what they call the luminal androgen receptor subtype. There have been several trials in AR positive. I have it in quotation because there's really no accepted uniform way of documenting AR positivity and triple negative. And what you can see in the ones with clinical results, a mostly clinical benefit as opposed to response. It is a small percentage of triple-negative breast cancers, and it does raise the question of, since we don't know what normal progression-free survival, and these were non-randomized trials, it's kind of a little bit hard to say whether this is natural history or whether there was actually a drug effect. So I would call this at the moment, and this is something I think is still worthy of pursuit as many people do, appealing, but at most we can only talk about a modest endocrine effect, although there may be some opportunities for just synergism and improvement. And then let's turn our attention to the microenvironment. So again, immune checkpoint inhibitors in metastatic triple negative, we can say a few things about them. Number one, they have modest activity as single agents. Second is PD-L1 status does matter here, and unlike early triple negative. And line of therapy matters. So it really works in the first line setting and not in pre-treated patients, and it works best if you combine with chemotherapy. We have two trials, of course, that are particularly relevant here, the Impassion 130 and Keynote 355. The outcomes are both are shown here. One was nab-paclitaxel with or without atezolizumab that showed that Kaplan-Meier curve in PD-L1 positive with a PFS advantage of 2.5 months and an overall survival advantage of 7.5 months. No real impact in PD-L1 negative. And after a negative trial, Impassion 131 with paclitaxel came out, the approval for this drug was withdrawn in the US a couple of months ago. Keynote 355 was chemo of a couple different varieties with or without pembrolizumab. And again, in PD-L1 positive, you can see the Kaplan-Meier curves demonstrating a PFS of little over 4 months. And what we just heard earlier this week from Dr. Cortez was an overall survival advantage, again, about 7 months. So this is a terrific advance, right? Impact is very real. I think many of us would have liked to see the tail be a little higher, but you know, it is real and it's wonderful. It is limited to PD-L1 positive, which makes about 40% of metastatic patients, and there are a lot of efforts to try and extend this benefit to PD-L1 negative through combinations, et cetera. And I think we should all acknowledge also that the strategy after relapse, if the patient got it in the neoadjuvant setting, is a little bit unclear. And then finally, what about what this means in the community? So I'm going to go back to CBCS3 and just comment that in CBCS3 we did molecular subtyping on the tumors in the participants, or a subset of them, and even more striking differences by race are seen when you're doing molecular and biologic subtyping. Specifically, the luminal A is very much underrepresented in young Black women. It's young women or Black women, so if you put the two together. And that's at the cost of having higher basal-like. So this just extends further the findings that we had in the early setting, in the earlier CBCS setting, I mean. And then what about outcomes? So again, CBCS phase 3 had patients diagnosed between 2008 and 2013. And so we have relapse-free survival a little over 5 years that was shown here. And a couple of things. If you look at the basal-like subtype, which is in the red on the bottom, you can see it is the poorest prognosis group. So not surprisingly, it also doesn't really matter if it was a white patient or a Black patient. So unfortunately, poor prognosis is poor prognosis. It is, however, more frequent in Black women, so it contributes to poor outcomes in that group by virtue of the distribution and being enhanced in the Black population. And of note, as we've seen before, the biggest within subtype racial disparity in outcome is actually the luminal and also apparently here the HER2 subtypes. So there's other burdens of this disease. So again, I have the pleasure of fantastic molecular epidemiologists around me. I also have the pleasure of fantastic health services researchers working in Carolina Breast Cancer Study. So in phase 3, they did ask patients to self-report. They had questionnaires periodically throughout. They were all planned. And so financial toxicity self-reported within 2 years of diagnosis is a kind of a stunning result. And you can see here by Black and white, this is financial toxicity. In this North Carolina population, it's quite substantial. Our patients are really suffering in a way that we don't capture very well. Separately, when they were asked about employment effects, 39% of these patients reported altered employment, especially if they were young, they had received chemotherapy, or they were uninsured. So if you put those together, you can imagine, while they didn't provide the analysis broken out by subtype, you can imagine that this is going to be affecting triple negative in particular. So our focus on improving treatment is appropriate, but burdens of this disease come to our patients in many ways. So triple negative, where are we going? So we started capturing this, in 1998 to 2005. We got better at chemotherapy for a few years there. Then we had, I think, a few years of things that just didn't work. But I think we've turned the corner, and that's why I actually have some excitement about where I think things are going. And we have a lot of new ideas emerging to augment our targeting, prevent immune evasion, and maybe even prevent triple-negative breast cancer. So the take-home messages here is, first, while triple-negative breast cancer is mostly basal-like, there's a lot of biologic heterogeneity in the tumor and microenvironment. Cure rates have gotten better. And this is attributable to chemotherapy up to now, but the impact of immune checkpoint inhibitors is likely to accelerate this further. Outcomes are in the metastatic setting are likely to be altered from these new drugs that I've just talked about, but we still need some big transformations. And I think it's worth noting triple negative particularly affects young women and people of color, contributing to poor outcomes of all kinds, and we have to pay attention to treatment, comorbidity and toxicity management, and improve social support. So I have deep appreciation for the clinicians caring for these patients, the researchers trying to create the knowledge that's going to help clinical care, the advocacy community that's reminding us that time is of the essence, but even more to our patients, like my patient above who lived with metastatic triple-negative breast cancer for 8 years. There are partners in donating tissue, participating in trials, and keeping us centered on what's really important. We have to do better. Thank you.